The trachea or windpipe is a tubular passageway for air. It's about 5 inches long and it's anterior to the esophagus and extends from the larynx to the superior border of the fifth thoracic vertebrae, T5. And at that level, it's where the trachea is going to divide into right and left primary bronchi. The trachea is lined with an epithelial layer of ciliated pseudocolumnar epithelial tissue, so it has the same protection against dust and debris that the mucous membrane of the nasal cavity in the larynx provides. The primary structure of the trachea is 16 to 20 incomplete horizontal rings of hyaline cartilage that look very much like the letter C. So they're stacked on top of each other and connected by dense connective tissue. You can feel these if you palpate just inferior to your larynx. The open part of each of the C-shaped rings faces posterior toward the esophagus, so that strip of soft tissue in the opening of the C is near the esophagus and allows for some expansion of the esophagus as we are swallowing food. The C-shaped cartilaginous rings also provide a sort of semi-rigid support that keeps the trachea from collapsing. Before we move on, let's talk just briefly about tracheotomy and intubation. So there are several conditions that can block airflow and obstruct the trachea. So those rings of cartilage that we talked about could be accidentally crushed, or the mucous membrane could become inflamed and swell so much that it closes off the passageway. Perhaps it's just excess mucus being secreted by inflamed membranes that clog the lower respiratory passages, or a large object could be aspirated or breathed in, or maybe there's a cancerous tumor that may project into the airway, or perhaps you swallowed food down the quote-unquote wrong pipe, right? So anything that obstructs the airway is going to need or is going to require that there's something done to establish airflow past the obstruction. So if the obstruction is above the level of the larynx, a tracheotomy can be performed. So in this procedure, a skin incision is made, and it's followed by a short longitudinal incision into the trachea. Just below the cricoid cartilage, a tracheal tube then can be inserted to create an emergency air passageway. The second method is intubation, where a tube is inserted into the mouth and nose and passed inferiorly through the larynx and the trachea. So the firm wall of the tube is going to push away or push aside any flexible object, and the lumen of the tube provides a passageway for air. So any mucus clogging the trachea can be suctioned out through the tube also. The trachea is going to branch into a right primary bronchus, which goes to the right lung, and a left primary bronchus, which goes to the left lung. The right main bronchus is more vertical and shorter and wider than the left. And as a result of that, if you do aspirate something, it's more likely to enter and lodge in the right bronchus than the left. Like the trachea, the main bronchi contain incomplete rings of cartilage, and they're lined with pseudostratified columnar epithelial cells. The bronchi are going to divide into smaller and smaller bronchioles that are going to branch and branch, and the smallest ones are going to branch into even smaller tubes called terminal bronchioles. The terminal bronchioles represent the end of that conducting zone that we mentioned earlier, and remember, it was the conducting zone that provides the pathway for bringing gases in. So this extensive branching from the trachea all the way to the terminal bronchioles looks like an inverted tree, and therefore it's sometimes called the bronchial tree. Beyond the terminal bronchioles of the bronchial tree, the branches become microscopic. The respiratory passages from the trachea to the alveolar ducts contain about 23 generations of branching, so it's very highly branched. Branching from the trachea into the main bronchi is called the first generation branching, and from that the main bronchi branch into the lobar bronchi, which are the second generation, and so on until you get all the way down to the alveolar ducts. So I wanted to include this image so that you could get a visual of how highly branched this brachial or the bronchial tree is. The lungs are somewhat cone-shaped organs located in the thoracic cavity. They're separated from each other by the heart and the other structures that are found in the mediastinum. Remember, the mediastinum separates the thoracic cavity into two anatomically distinct chambers. So as a result of these lungs being separated into separate chambers, if trauma causes one lung to collapse, the other can remain expanded. So each lung, remember, is enclosed and protected by that two-layered serous membrane that you learned again back in Anatomy 1. And that was the serous pleural membrane. So if you remember back to then, the pleural membrane is divided into a parietal membrane that lines the wall of the thoracic cavity, and the deeper layer was the visceral pleura that lies on the surface of the organ itself, so on the lungs. Remember, viscera means organ. Between the visceral and the parietal pleura, there's a space, and we call that the pleural cavity, and it's going to be filled with a small amount of serous fluid secreted by those serous membranes. This fluid reduces the friction between the membranes and allows them to slide easily over each other during breathing. Separate pleural cavities surround the right and left lungs. Inflammation of the pleural membrane, called pleurisy or pleuritis, in its early stages can cause pain due to friction between the parietal and the visceral layers of the pleura. If the inflammation continues, excess fluid can accumulate in the pleural space, and that's what is known as pleural effusion. In certain conditions, the pleural cavity may fill with air. That's called a pneumothorax, or blood, hemothorax, or even pus in cases of injuries and infections. So air in the pleural cavities, most commonly introduced through a surgical opening of the chest or as a result of a stab or a gunshot wound, can cause the lungs to collapse. This collapse of part of a lung, or very rarely the entire lung, is called atelectasis. The treatment of this is to get rid of the air or the blood from that pleural space. This allows the lungs to reinflate, and a small pneumothorax may resolve itself on its own, but very often it's necessary to insert a chest tube to help to remove that blood or air from the pleural cavities. Terminal bronchioles subdivide into microscopic branches called respiratory bronchioles. As the respiratory bronchioles penetrate deeper and deeper into the lungs, the epithelial lining changes from simple cuboidal to simple squamous. Think about the importance of that. Simple squamous, what does that mean? One layer of thin, flat cells. The respiratory bronchioles are then going to subdivide into several alveolar ducts, which consist of simple squamous epithelial. Now remember, the conducting zone ends at the terminal bronchioles, and the respiratory zone begins with those respiratory bronchioles. The respiratory zone is going to end at the alveoli, or the air sacs that are within the lungs. In this image you can see the respiratory bronchiole giving rise to alveolar ducts, and then you see these big clusters. These clusters are called alveolar sacs, and the alveolar sacs are made up of individual alveoli. So I often describe your alveolar sacs as like a cluster of grapes, and each individual grape would be an alveolus. The walls of each alveolus, now that's singular, alveoli is plural, so the walls of the alveolus consist of two types of alveolar epithelial cells. The type 1 alveolar cells are more numerous. They're the simple squamous epithelial cells that make up most of the lining of the wall of the alveoli. The type 2 alveolar cells are fewer in number, and they're found between the type 1 alveolar cells. So a thin type 1 alveolar cell is the main site for gas exchange. The type 2 cells secrete alveolar fluid, which keeps the surface between the cells and the air moist. Included in the alveolar fluid is surfactant, which is a mixture of lipoproteins and phospholipids. So it has a very slippery, much like detergent texture to it. So surfactant lowers the surface tension of the alveolar fluid, which reduces the tendency of the alveoli to collapse and helps to maintain their patency or keep them open. Also present in the alveolar wall are alveolar macrophages, which are phagocytes that remove fine dust particles and other debris from the alveolar spaces, and also there are fibroblasts that produce reticular and elastic fibers. The exchange of oxygen and CO2 between the air spaces in the lungs and the blood takes place by diffusion across the alveolar and capillary walls. Now, the alveolar wall and the capillary walls together form the respiratory membrane. The respiratory membrane consists of 4 layers: a layer of type 1 and type 2 alveolar cells and the associated macrophages that are found that make up the alveolar wall, an epithelial basement membrane which underlies the alveolar wall, a capillary basement membrane that's often fused to the epithelial basement membrane, and the capillary endothelium. Even though there's several layers there, the respiratory membrane is very, very thin. It's only about 0.5 micrometers thick, about 1/16 the diameter of a red blood cell. So this allows for very rapid diffusion of gases. It's been estimated that both lungs contain between 300 and 500 million alveoli, so that gives us an immense surface area for gas exchange, about the size of a racquetball court. The hundreds and hundreds of millions of alveoli account for the spongy texture of the lungs. So before we move on, let's talk just a little bit about some disorders associated with this gas exchange. So there are many viruses that can cause coryza, or what we commonly call the cold. But it's a group of viruses called rhinoviruses that's responsible for about 40% of all colds in adults. Typical symptoms include sneezing, runny nose, cough, congestion. The uncomplicated cold is usually not accompanied by a fever. Complications include sinusitis, asthma, bronchitis, ear infections, and laryngitis. Recent studies show an association between emotional stress and the common cold. The higher the stress level, the greater the frequency and duration of colds. Seasonal influenza is also caused by a virus. Its symptoms include all of the ones with the cold, but it also has fever and chills, usually higher than 101 degrees Fahrenheit or 39 degrees Celsius. Also usually accompanied by headache and muscle aches. Seasonal influenza can become life-threatening and may develop into pneumonia, so it's important to recognize that flu is a respiratory disease, not a gastrointestinal disease. Many people think that they have seasonal flu when they really just have a mild GI illness. H1N1 flu, also known as the swine flu, is a type that's caused by a new virus. This virus is spread in the same way that most seasonal flus spread, from person to person through coughing or sneezing or touching things that are infected because people don't wash their hands, or touching your mouth or your nose, and then, of course, spreading those germs onto a surface where someone else picks them up. Most individuals that have the H1N1 virus have mild disease and recover without medical treatment, but some people do have a severe disease, and others have even died from this. So the symptoms of the H1N1 flu include fever, cough, runny nose, stuffy nose, headache, body aches, chills, fatigue. Some people have diarrhea and vomiting. But most people who've been hospitalized for H1N1 flu have one or more pre-existing medical conditions such as diabetes, heart disease, asthma, pregnancy, kidney disease. People infected with the virus can infect other people from one day before symptoms even show up to 5 to 7 days after they occur. Treatment of the H1N1 flu involves taking antiviral drugs such as Tamiflu or Relenza, and also a vaccination is available, but the H1N1 vaccine should not be considered a substitute for the normal seasonal flu vaccination.